And it's not like, oh, have a good night's sleep and you'll feel better. It's not that kind
No.
of fatigue. It doesn't go away with a good night's sleep. That's the problem. And the brain fog is real. There's real central nervous system effects of low iron. People can't function, they can't calculate. I've known people who are accountants who can't do their work. I don't hematologists know. I'm a hematologist and it's not in any of our textbooks.
No, I know.
It's not
Amazing,
taught.
isn't it?
And my
Amazing.
colleagues don't know this.
You would see baby hairs developing after a few months. But ferritin needs to be above 80 at least for optimal hair growth.
And I've been given a date for maybe 3 weeks in the future, 4 weeks later, and I say, well, we can't wait this long because this patient is so symptomatic. We cannot wait 4 weeks.
I've never had anybody come back and say it didn't work, which to me is a big thing, because people would always come back and say, look, I don't feel any better if they didn't. Welcome to our podcast today. I'm Dr. Susan Jain, a consultant in intensive care medicine and anaesthesia in London, and lead doctor at Revive and Reset, where we focus on intravenous iron therapies, amongst other general health measures. Today, I'm talking to Dr. Drew Provan, who's a consultant haematologist, and he shares a passion of mine, which is anaemia, but more specifically, iron deficiency anemia. Drew, welcome. Tell us a bit about yourself.
Thank you, Susan. Well, I work in London as a haematologist. I've been in haematology for 40 years or more, probably. I have a major interest in benign haematology, autoimmune haematology, iron deficiency. I've written for the BMJ and the Lancet and in my textbooks about iron deficiency over the decades. So I have a big interest in iron deficiency.
Great. So you are the perfect person to be here today with me to talk about anemia and iron deficiency. And without further ado, let's start with, what is anemia and what are the commonest causes?
Well, anemia, by definition, is simply a haemoglobin that's below the normal reference range for age and sex. That's it. Okay. It's not a diagnosis. It's not a disease. It's simply when your haemoglobin is below the normal reference range. And
there's a difference. We have different reference ranges for ladies and gents, don't we?
We do. We have many reference ranges.
Okay.
We have them for males and female adults.
Yep.
And then in the pediatric setting, again, they have their own ranges.
Okay.
So there are many reference ranges.
So in the adult population, what are the reference ranges for males and females?
For females, it depends on the lab, but usually something around 115 grams per litre would be anemia for a female, and for a male, probably around 135 grams per litre for a male.
Okay. Yes, and that is give or take about sort of, either side. It can be 120 and
Absolutely.
130 sometimes. So yes,
it can be. Yes, it depends on the lab.
And what are the commonest causes of anemia? So a low haemoglobin.
Worldwide, it's about 1.5 billion people have iron deficiency, and 1 billion people of those have iron deficiency anemia. So a lot of people have iron deficiency without obvious anemia.
Okay. Yes, I'm glad you mentioned that, because this is one of the questions that a lot of my patients ask me when they present with their blood results, and they say, look, I'm feeling terrible, I'm feeling fatigued, I've had my bloods checked, and my regular doctor tells me that my haemoglobin is fine, but my iron might be low. I don't really know what this means. So we know, you and I know, that it's possible to be iron deficient without being iron deficient anemic. But what does that mean in reality?
Well, this is really common. This is incredibly common. People feeling washed out with brain fog and all the symptoms of iron deficiency with a normal haemoglobin. And within the medical profession, it's often reassuring to see a haemoglobin that's normal. But this is a false reassurance. It doesn't mean everything's normal. Below the surface, the other cells are lacking iron. So they're not functioning well, although the haemoglobin is maintained. So this is a very false reassurance of optimal health, if you like.
Okay, yes, so optimal health. And as we've talked about before, iron is necessary for the functioning of every cell in the body. And that's what we're looking at. So it doesn't matter that the haemoglobin is normal. One can feel quite unwell with just simply iron deficiency.
Absolutely. The body seems to prioritize iron towards the red cells. And of course, don't forget, red cells live for 4 months. They have a long lifespan before they die off, in a way. So your anemia takes quite a long time to develop as the iron deficiency progresses. So in the earlier stages, the other cells around the body, all cells require iron. And all the cells that require iron don't have the iron they need. The muscle cells, the nerve cells, the brain cells. And that's why they have those symptoms. Meanwhile, in the background, the red cell population remains fairly static because they live a long time, the red cells. and they have enough iron for what they want to do, but the person generally feels incredibly symptomatic despite what would appear to be a very healthy hemoglobin level.
Okay, so left long enough, plain old iron deficiency would become iron deficiency anemia.
If the losses, for example, or the intake of iron is insufficient to keep up with demand for red cells, then the hemoglobin over time will fall. The hemoglobin is the last thing to fall in iron deficiency. The ferritin, for example, the stores will fall gradually over time and then hit rock bottom. And then at that point, the hemoglobin will take a downturn and then will become low. And of course, I've seen patients with hemoglobins of 40 grams per litre, which is grossly anemic.
Yes.
Somehow functioning just about. But it's a very, very late feature of severe iron deficiency is the low hemoglobin.
All right, so let's talk a little bit about how we measure iron deficiency itself. What about the ferritin? What is ferritin, and when does it represent iron deficiency, or when does it represent the iron stores?
Okay, well, there are many tests we use for iron deficiency, most of which are not particularly helpful. The ferritin is a protein which is made by the liver, and it's made in response to iron surplus, if you like. It's the protein which stores iron in the liver for use by cells. It's our store of iron. So if your intake is insufficient, then the stores will be low and the ferritin will be low. There's nothing to store, therefore there's no point the body making ferritin if there's nothing to store in the ferritin. So it reflects your iron status in terms of your iron stores.
Yes, and what kinds of levels of ferritin are considered normal? I know, as I ask this question, I know it's a contentious issue because we have reference ranges, which are, well, I'll let you explain.
Yeah.
Yes.
We do have reference ranges for ferritin, of course, and it goes from something as low as 13 right up to 200 for a female and 13 to 300 for a male. But 13 is incredibly low for a ferritin, but it's still within the normal reference range, if you like.
Yes. Yes. So the World Health Organization tells us that if you have a ferritin of below 30, really you are iron deplete, and below 15 you have iron deficiency. And we talked a little bit about optimal health before, didn't we? But
Yep.
I think, and maybe, I don't know, tell me whether you agree or not, that for optimal health, ferritin should be really somewhere around 50. And of course, different people are symptomatic at different ferritin levels.
That's absolutely true. I mean, it depends on the person. Some people tolerate a ferritin of 30 and can feel fine, but often not. And some people require a ferritin of 40 or 50 to feel normal without brain fog and to have their normal energy level. So it varies slightly from person to person, and it depends on their age, their comorbidities, and many other factors, of course, contribute towards the feeling of wellness or unwellness, if you like.
So really, in any assessment of a person, it should be done with the blood results and their symptoms in hand to decide what needs to be done next.
We would never act on a blood result alone. We always have to take the whole patient into account, their history, what medicines they're on, what comorbidities they've got, what their job is, their expectations. There are many things we have to take into account. We would never act on or prescribe anything simply based on one blood results. As you know, we would never do that in medicine.
Yeah,
thankfully.
Of course. So I would probably say to people that if they do get blood results, such as including a haemoglobin and a ferritin, they should ask what the actual values are, rather than have somebody say to them, we've looked at your blood results and they're fine. Because often there's a misinterpretation, I think, with those results.
I think that's absolutely true. I think patients should take control of their result. They should be aware of their results numerically. What is the result? The GP or some other doctor may see a ferritin of 15 or 20 and say it's fine because it's within the reference range, but that's not fine. We need to know the ferritin absolute value and other things as well, like the transferrin saturation. Again, ferritin alone is not useful.
So why is ferritin not always reliable?
Well, if the ferritin is very low, it is reliable. A very low ferritin means a very low ferritin, and there's only one thing gives you that, and that's iron deficiency.
Okay.
If, however, the ferritin is normal or even elevated, that may not be a true reading because ferritin, as you know, is an acute phase reactant, acute phase protein, and will go up with inflammation or infection, or if the body is, if you're unwell, if you're post-operative, for example. So the ferritin in isolation, you have to be very careful. As I say, low ferritin, you can rely on that. A normal ferritin, you have to say, well, what is the saturation? is that normal? Because if that's low, even though the ferritin is normal, then it does indicate iron deficiency as well, even with a normal ferritin.
Yes.
If you know what I mean.
Yes. So in those people who have a chronic state of inflammation, maybe some background diseases, their ferritin might be running a little bit higher. And in that case, the transferrin saturation is useful to look at because it will accurately reflect whether or not they have iron deficiency.
Yes, that's absolutely, yeah, that's true. And also, the other thing which is useful would be something like a C-reactive protein value or perhaps an ESR test. If they are elevated as well, then you know the ferritin is falsely elevated. And then you then do have to rely on the saturation really to tell you what is actually going on with a patient.
But even something as simple as having had a bout of flu can lead to a temporarily raised ferritin. And in that situation, people have come to me and they said, oh, but my ferritin was quite high. And I said, were you ill? And they said, yes, I did have a cold. And then we've looked at their transferrin saturation and it's low and it matches the story and everything. So that works out, I think. Okay, so we're definitely aiming for optimal health. And now that we've decided that we found people, we've identified iron deficiency, what about the best ways to deal with it? What are we going to tell these people? How are we going to help them to plan their journey forwards?
Well, of course, the standard therapy for iron deficiency would be to offer oral iron replacement therapy. That has been historically the standard of care for iron deficiency.
Yes.
Which would mean taking iron tablets, and there are many different types of iron tablets.
Yes, but what are the pros and cons about oral iron replacement?
Well, there are pros, but there are not many pros.
No.
The pro, I mean, it's cheap.
Yes.
It's easy.
It's
You can do it at home.
Yes.
I guess that's on the pro side. On the con side, they all, irrespective of which type of iron it is, they all have side effects like abdominal pain, constipation, black stools.
Yes, it's all the gastrointestinal system.
Upset.
Yes.
That's the problem.
Yeah.
No matter how you market it and bind it to something else, there's always a bit of gastrointestinal upset, which then reduces compliance as well. The patients don't like taking them, and if we suggest you have to take these for many months, it doesn't go down terribly well with the patient population. It's difficult to take something that causes you all these problems for months on end.
Yes. And even if there's been good compliance for a few months, there are a couple of studies out there that have shown that the ferritin level doesn't really rise that much.
Well, yes. I mean, we've been talking about this, and like, how often, if you take your iron optimally orally, how often would you achieve an optimal ferritin level of 40 or 50 with oral replacement? And I think from the studies we've looked at, it's not common. Even after many months of good compliance, it's hard to get to a really optimal ferritin level.
Yes. And then if you look at why there's iron deficiency in the first place. So the biggest cohort of patients that I see are premenopausal women who are simply having heavy menstrual bleeding. And if they're having ongoing bleeding, then they are unlikely to be able to maintain their iron stores.
I agree completely. I think in the world of iron deficiency, I think menstrual blood loss is the commonest cause by far.
Yes.
And when I talk to patients, I often say it's a bit like your bank account. If you withdraw more than you put in, you're going to be in the red constantly. And we're trying to top up their bank account with the oral iron, but we can't keep up with the losses. That's the really difficult part.
Yes. Okay, and what about when do you? I mean, I'm going to talk a little bit about intravenous replacement, though, obviously. But when you've seen in your practice, how long do you think people have persevered with oral iron before looking for different routes?
Well, within the National Health Service, I mean, I'm talking within the NHS practice, we do try to get patients to take iron for a fair while, 2 or 3 months, if they can tolerate it, and then we repeat the bloods. If they feel better and their ferritin has gone up, then we say continue for another 2 or 3 months as well, persevere. So it's about 6 months in total. But some people, during that period, they feel no benefit. Their ferritin hasn't shifted at all. They still have the ongoing brain fog, fatigue, and all the other problems that they had.
Yes.
And then we have to have a discussion about what to do next. And that's the difficult part, as to what to do next. Do you simply switch to another iron preparation, and say, try another 6 months? So that's a year out of their life where they're not functioning properly. They may have demanding jobs, they may have young kids, and life is very difficult because you've got this constant feeling of being drained with brain fog. And the brain fog is real. There's real central nervous system effects of low iron. People can't function, they can't calculate. I've known people who are accountants who can't do their work because the brain fog is so intense.
Yes. And I can testify to that because I've experienced it.
Yeah.
So it is real. And really, you feel like you're wading through treacle.
It is. And it's not like, oh, have a good night's sleep and you'll feel better. It's not that kind of
No.
fatigue. It doesn't go away with a good night's sleep. That's the problem.
Yeah.
But again, it's all the cells that are deprived of iron around the whole body, not just the red cells, which I often find. It's all the other cells that you need to function, the mitochondria
Yes.
and everything, your energy, your
Yes.
powerhouses
I think
are not
especially
firing.
in the muscles as well. That really becomes
Totally. So
quite
it's very
apparent.
difficult within the health service in terms of what we do next. They would prefer us to persevere with different oral irons, but of course we do have the option of intravenous iron. But maybe we can get round to describing which patient would end up getting IV iron on the NHS, because it is difficult to get IV iron on the National Health Service.
Yes. I think on the NHS, the only patients really that are receiving intravenous iron would be those going forward for operations where there's significant blood loss, or they're also starting off anemic, so with a low haemoglobin, and not just iron deficiency. I certainly, and also possibly in intensive care practice as well, where patients have been chronically unwell for many months, and they would be benefiting from receiving intravenous iron. But there are very few places, I think, where it's being given out.
No, I think you're absolutely right. And again, it comes back to our focus on the haemoglobin.
Yes.
Within the health service, there is a pro forma, and it often asks you what the target haemoglobin is that you're aiming for with your iron therapy, your IV iron therapy.
Yes.
So if your haemoglobin is 120 to begin with, then the target is 120 as well. So you get denied iron. But I've managed to persuade my hospital on occasions when the patient feels so wretched despite a normal haemoglobin, and I say this is all down to iron deficiency and the saturation is low.
Yeah.
Can we please give IV iron? And I've been allowed to do it, but it is difficult for general practitioners to get access to IV iron. It's even difficult within a haematology department to get on the day ward people to get IV iron because, again, of this fixation on the haemoglobin, which is frustrating to say the least.
Yes.
Why we fixate on this one value which tells us nothing. But
That's
it's
right.
historical.
So, of course, inflammatory bowel disease patients and heart failure patients do have a different route through which they get iron. Even that is not up and down the country. It's not uniform. It's not standardised, I feel. But that's another matter. So really, the population of patients we're talking about are those out in the community who have iron deficiency for a blood loss reason, such as heavy menstrual bleeding, or possibly celiac disease, where they haven't been diagnosed, and that might account for a small amount of people as well. There are those who've had their gastric bypass surgeries in the past who have poor absorption of iron thereafter, and then that would probably account. And then actually, what about strict vegetarians? I think they probably come into the mix as well.
They do. There's, in terms of patients where it's easy to get IV iron, the post-bariatric surgery patient will not absorb oral iron. So they are candidates for IV iron. I think within the NHS would agree they would get IV iron fairly easily.
Yes.
People with inflammatory bowel disease, for example, Crohn's, who cannot absorb iron, again, they would get IV iron almost routinely. We know they can't absorb iron. Vegetarians and vegans is slightly different. It's not an absorption problem. It's a lack of availability of the iron. So that's suboptimal diet in a way.
Yeah.
That would be harder to persuade people to give IV iron in a sense. But I mean, those are the minority of patients. I think 90% are going to be due to menstrual blood loss in premenopausal women, of which there's a massive cohort out there who are being treated kind of suboptimally within the health service.
Yes.
Struggling to take something that doesn't work very well and gives them lots of side effects.
Yes.
And the net benefit to them is minimal. And it's frustrating that we're treating people suboptimally, really.
I think so. And for them, although they might be trying oral iron, perhaps another route to be looked at would be intravenous iron. And if they're happy to do that, then, certainly that's something we can help them with. Yeah,
no, I totally agree. Absolutely. It's just, I think we wait too long. But again, it's due to resources and spaces on the day unit. There's many restraints on a day ward within a hospital and many pressures for there's competition for the beds on a day unit as well, and the iron patients often get squeezed out, unfortunately. I've tried to get people in who desperately need iron, and I've been given a date for maybe 3 weeks in the future, 4 weeks later, and I say,
Yes.
well, we can't wait this long because this patient is so symptomatic. We
Yes.
cannot wait 4 weeks. So they're often deprioritized compared to other conditions maybe on day units. There's a lot of pressure within the health
Yeah.
service.
What's your experience of intravenous iron in the private setting?
Well, then intravenous iron in the private setting is very straightforward.
Yes.
I haven't given as many IV infusions of iron as you
Yes.
have, but what I have done is very straightforward. There's no pushback from
Yes.
anyone. I decide as the clinician, this is why my patient's symptomatic. This is the course of action I want. I prescribe the iron and it's given, and then it's all very straightforward. And recovery is faster, and they don't have to go through these months of waiting for a ferritin to gradually creep up at glacial speed to something that's still suboptimal 6 months later. Is night and day within the private sector, really.
Yeah. Okay. Well, maybe we can talk a little bit more about intravenous iron.
Absolutely. Yeah. I'd like to ask you, because many people are going to want to know the ins and outs of IV iron, like eligibility and what it's like.
Yes.
So in terms of the people that you give IV iron to, and you've given like 2,000 or
Yes.
more IV iron infusions, is like, who's your typical patient? I think you've alluded to this already.
So
but
yes, we have. Yes, the typical patient that I've treated in the private sector giving iron to would be a premenopausal lady who has heavy menstrual bleeding and simply can't keep on top of the losses, and variably has tried oral iron supplementation but has failed because of lack of compliance, side effects. Some of these ladies have also been put onto antidepressant tablets or advised that because their haemoglobin is normal, then it's okay, but they've still remained quite fatigued with brain fog and poor functionality.
And you mentioned vegetarians and vegans earlier.
Yes.
What proportion of your population are those who cannot absorb, say, celiac or bariatric or post-bariatric surgery, or are vegetarians and vegans? Do you see some of those as well?
Oh, absolutely. So probably maybe that category, so if you're putting all of those together, so maybe an absorption problem such as celiac together with a strict vegan, vegetarian diet and the post-bariatric surgery would maybe make up 5%, 5 to 10% of the people that I see. So I would say that, yes.
And of those women who get IV iron, say for menstrual blood loss, how many of those have the iron repeatedly? This is not a one-off treatment, is it, IV iron?
Well, it could be.
Could be?
It could be. It depends on the reason for the iron deficiency.
Okay.
So if it's ongoing blood loss, then one would look at whether or not that blood loss could be controlled, whether it's appropriate. So maybe look at other sort of gynecological causes for heavy menstrual bleeding that could be treated, and then see if ferritin iron stores can be maintained thereafter. We would always hope it's a one-off. However, I would say that we've probably, in my experience, I've seen about 60% of people don't come back and 40% of people do at variable times.
Oh, that's interesting. Okay, that's
Yeah.
good. So it can be just one-off, but some people
Yes.
have to have it once or twice a year
Yeah,
if they have
something
ongoing
like-
heavy menstrual
yes.
blood losses and they can't keep up.
And they can't control it, or they haven't, there's nothing to treat, or, yeah.
And in your practice, how long do you give people on oral medication before you've decided it's failed? Say oral iron.
Yeah, I would say a good 3-month stint of taking oral iron in the way that we should be, which is on alternate days, first thing in the morning, on an empty stomach, washed down with a glass of orange juice. And if they've had poor compliance or they've had side effects and they haven't reached the 3 months, that also is a reason to then go down the path for intravenous iron.
And do you think some of the failure to respond to oral iron is a compliance issue, or do you think people are really complying properly and it's just not working?
That's a difficult one, isn't it? Yes. But I think that a lot of people talk to me about side effects. People say, oh, I took it, but I just couldn't stand it because I had, loose stools, I had constipation, I had terrible stomach cramps. So I do hear a lot about that. I do feel that people are trying to give it a good go because they will have been through primary care in the first instance.
Okay. And do you know why people get such bad... What causes these side effects? Do we know? I'm not really sure what it is. I know it's quite astringent, maybe, the iron. Is that... I don't really understand what causes the... I don't understand the constipation. Or what causes... Why they get constipated?
I think it's the way it's prepared. It's the preparations that it's in. Yes, but it's also the metabolism of it at that point. But I don't think anyone really knows, though. But I do know that, the more concentrated the iron preparation, the worse the side effects.
And is this true of the liquid as well as the tablets?
Yes, but the liquid is always very low concentration anyway. So going from a spray through a liquid and then onto low dose tablets and high dose tablets, I think the concentration of iron goes up in that order.
Now, we were talking about oral iron really not bringing your ferritin up terribly well. Do I recheck the ferritin? I think we do check ferritin in some of them, and it never goes particularly high, I don't think, with the oral medication. I'm not sure we achieve a ferritin of 100, for example, with iron tablets. Is that your experience as well?
I've certainly never seen that, yes. I've had people, again, so I have had a fair few ladies who have said, look, I took some iron for a good 3 months, and they really have done it. And my ferritin went up from 10 to 21 or something like that, which, of course, they're still in the iron deficiency bracket and still feeling, and more importantly, still feeling quite unwell. And
it's surprising in a way the ferritin doesn't go up. The reason I'm saying that is because normally from our diet we absorb around 1 to 2 milligrams of iron per day through our diet. And yet at times of iron deficiency, the body can ramp up the absorption, can't it, quite a lot? What can it go up to? Is that something like 6,
it's
7,
5
8?
Or 6, yes.
It can go up like 6 times the normal amount. Yet despite that, and we're flooding them technically with iron, it's a lot of iron. 65 milligrams a day or every other day of elemental iron.
Only about 10, maximum 20% of that iron is going to be absorbed.
Yeah, of course.
So there's that, there's that,
there's
that to consider,
So I think what people would like to know is what actually happens, what's the logistics and what happens on the day. So imagine I'm a patient and I want intravenous iron with you. What do I do? What's the procedure? What happens?
Okay, so you would call us at Revive and Reset with your blood results in hand, knowing that you had iron deficiency, most probably. And then we would set about to arrange a consultation online for 30 minutes. And that would be a proper look into why you have iron deficiency. We'd go through it all, and it wouldn't just be an assumption that you're iron deficient. We would look at it, think about how we could tackle it, and maybe discuss other appropriate referrals to specialists if necessary in other kinds of in other worlds, such as gynecology or gastroenterology. And then we would arrange for you to come in for an iron infusion. Now, what I would then say to the patient is, on the day that you come in, we'll give you an hour slot. And on that day, please drink plenty, because we need good veins. And we need good veins because if iron comes out of the vein at all, it can stain under the skin like a tattoo. So we're always very cautious about that. It's rare, but it's one of those things that's out there on the forums. And I find that people talk about it. There are just some case studies out. So it's one of those rare but well-recognised complications.
I've seen it as well. I've seen the same thing within the health service as well. It's the whole arm, and it takes a long time to go.
But it's easily avoided, I feel, in the first instance. So once cannulated, I would know whether or not that cannula is in the vein.
Sure.
And that's by simple flushing. And then, only then, when I'm happy, is the iron infusion set up, which we expect to run for about 25 minutes or so. And then during that time, I would say that there's a couple of things that can happen. One is an anaphylaxis, so a true allergic reaction. And that's about 1 in 10,000 people, of the order of somebody being allergic to an antibiotic in the general population, for example. And if we think that's happening, we would simply abandon, give steroids, and that would be that. The other thing that can happen is something called a hypersensitivity reaction, which is about 1 in 60 to 1 in 100 people, whereby people can feel a little bit flushed. They might get this heat rise, they might feel a bit of a scratchy throat, and that's also something we would just stop the infusion immediately. And at this point, we would then wait a few minutes until all those symptoms are gone, and then we restart the infusion, and the same thing would not happen again.
Right, okay.
I've seen a few of those because, as I said, the incidence is about 1 in 60 to 1 in 100. But it's very easily dealt with. And once the infusion starts again, the same thing does not happen. And once the infusion's finished, we would ask them to wait in the waiting area for another 25 minutes just to make sure that there's no latent reactions, any itchy bits or any hives, something like that. If they did have some hives, a simple antihistamine would be the remedy to that. After that, they're free to go. And then I would say that for the next 24 to 72 hours, about 1 in 3 people might feel a bit flu-like. So in reality, what does this mean? Probably you might wake up the next morning feeling a little bit, the body might feel a bit flu-like. Mm-hmm. And if this was the case, some simple paracetamol or ibuprofen and hydration would do the trick, and it would pass. And the last thing I would warn them about would be low phosphate levels. Now, this is also something that's incredibly rare, however, talked about in the forums. So symptomatic hypophosphatemia is what I call it, because low phosphate isn't enough. In reality, most people who have an iron infusion, or a lot of people who have an iron infusion, will have a drop in their phosphate levels. However, in a very tiny percentage of people, the phosphate levels will drop low enough such that they might feel quite tired for a couple of weeks. And this would set in about a week after the iron infusion. And they might feel muscle pain, bone pain. It is self-limiting, and there aren't any chronic consequences to it, and it will eventually self-correct. It's just that when someone has an iron infusion, there's a substance that's released into the body which tells the kidney to pee out extra phosphate. And until that's gone, the phosphate will be lost. But it is rare, and in the couple of thousands that I've done over the last few years, only 2 have been picked up.
Okay, so that's interesting.
Yeah.
It sounds like in general you don't see much in the way of side effects. So people having the infusion occasionally might get the scratchy throat, but
yes.
the more serious adverse effects you just don't
yes.
see is small numbers,
exactly.
occasional, and most
yes.
people have it fine. A few people might get the low phosphate by this hormone that makes the kidneys excrete phosphate, and they might feel rough for a week or so, and then they feel okay.
Yes, but that's very rare.
No, okay.
It's rare.
And is there anything people can do if that were to happen to them? How would they know they had low phosphate? Do you check the phosphate level? Do they check the phosphate level?
No, but they would simply come back to us and say if they felt unwell. So there's always an open communication available. And
can you eat phosphate? Would it make you better if you ate high phosphate food, or you can't really? You have to wait it out for 2 weeks.
It out.
Okay.
It might be reasonable to replace the phosphate intravenously if the case was very severe. And again, there are some case reports of that, but it's incredibly rare.
So in terms of, I mean, I'm old enough to remember when iron was given intramuscularly, often by general practitioners, and that wasn't very popular because of the skin staining and the pain. And so luckily we've gone to IV.
Yes.
How many IV preparations are there, and are they all the same in terms of how they're given and maybe adverse reactions?
So in the UK, we have 2 preparations that we use, and the brand names are Ferinject and Monofer. And there's a couple of differences between them. Again, I think people may be reading up about them online as well, but they do exactly the same. They have exactly the same effects. There are some slight differences between them in that Ferinject is slightly more likely to cause the drop in phosphate levels, whereas Monofer is not. However, on the flip side, Monofer is more likely to cause some immediate reactions during the infusion. So it's always 6 of one and a half dozen of the other, I think, with these things.
So I've had my IV iron. It's taken an hour. I have had no adverse reactions. I've gone home.
Yes.
I feel fine.
Yes.
What do I do next? When do I recheck my blood? And what am I expecting in terms of my ferritin? Where would you see I might be if I was a young woman with heavy menstrual periods? What would you expect, say, when you check the blood? So tell me when we check and what you would look for.
Okay. Before I answer that, I would say to you, expect to feel better in a couple of weeks. So 10 days to 2 weeks, you might start to feel a lift in your energy levels, easier to get out of bed, that fatigue, that brain fog starts to improve, and you would get an improvement a continuous improvement between 2 weeks and 2 months.
Okay.
Now, coming back to when to check blood levels, and I do get asked quite a lot, what's my ferritin going to go up to? What can I expect it to rise to? It's very individual, and it all depends where you start, of course, and also depends why you're iron deficient and whether you're having ongoing losses of that iron for whatever reason. So, which is why, and also the body needs to assimilate the iron that it's given, and that iron is obviously 100% available to the body as opposed to the oral iron, which remember we said was only 10% or 10 to 20% absorbed. I would advise a blood check in about 3 months' time, because that's where that's when the ferritin's going to settle, and the body has used up all it needs to do and will be storing iron.
And what would you expect my ferritin to be? What would make you happy? What would be the ideal outcome for my ferritin? What level would it be?
I think above 100 would be an ideal outcome.
Okay.
Yes, and that would be a good place. I mean, at least that would be the very baseline. I think it would be disappointing if a ferritin came back at close to 30, which I have seen before, but that sort of represents ongoing blood loss.
And if I had hair loss and hair thinning, which is quite common,
yes.
very common with iron deficiency, when would I start to see an improvement in that?
That takes about 6 months, because the follicles that are programmed to shed will continue to shed, and then it takes time for new ones to be regenerated.
Okay.
So they've been the follicles get starved of oxygen, iron, and the hair falls out. But then it takes a few months for that and you would see baby hairs developing after a few months. But ferritin needs to be above 80 at least for optimal hair growth.
Now, you say
high.
that. You say that, but I think within medicine generally, I don't think many people appreciate that. I think in the medical fraternity, whether you're hospital doctors, haematologists, general practitioners, nobody realizes that. Why? How come we don't know this? Why don't we know this?
We're just not taught it, are we, at medical school, or even along the way? I didn't even realize until latterly, until I started having my passion for anaemia and iron deficiency.
I also wasn't so aware. And we have a thing, when drug trials are done for drugs, the drugs are licensed and then we start using it. And then we have real world data, real world when it's out in the wild, if you like, when we're using it. Yeah. And I think all real world data, patients reporting back, it's then really obvious you need a high ferritin if you want to regrow your hair and have really healthy looking hair.
Yes.
And
so trichologists know.
Why don't hematologists know? I'm a hematologist, and it's not in any of our textbooks.
No, I know.
It's not
Amazing,
taught.
Isn't it?
And my colleagues don't know this, and this is really surprising. So you have a lot of work to do in educational of educational patients, education of physicians and other specialties in terms of the optimum iron level for optimum health, because that's the thing you're doing different to medicine. Because in medicine's very reactive to disease, and we fix a problem when it's really bad. But you're intervening, hoping not to let people become so bad. So you're trying to optimize people's health rather than just patch them up.
Absolutely, and dare I say preventative medicine, because once you get to a point where you're not functioning, you're going to go off sick from work. Because, and again, a lot of the patients that I've consulted over the years have said, I've been off work for such a long time because I just can't get out of bed.
And the other thing which we're not good at in the health service is kind of anticipating when something will be needed, like an iron infusion. So we have someone with heavy menstrual loss who has IV iron. You suspect they're going to need it again. We don't try to work out we should see them and check the bloods down. We wait till it hits rock bottom again, which is not the way to do it. What's the best way to do it to keep them well?
I would say for those people, look at controlling the blood loss, first of all. So whether there is a treatable cause of the heavy menstrual bleeding. There are also tablets that can be taken to lighten the bleeding as well, which is well known in the gynecology world. So that's tranexamic acid. But of course, that's also prescription, so that's only done on medical advice, whether it's from us or from the general practitioner or from the gynecologist. And then keep on top of the iron levels with oral iron after an iron infusion. So that would be the time to bring in oral iron, I think, and it would probably be more effective because you filled up the tank slightly. And if you imagine it's just easier to top up iron, you could probably take oral iron twice a week, maximum 3 times a week, which would incredibly improve the compliance, reduce the amount of side effects, and then that would be easy enough.
Yeah, no, I agree. And I think, I agree with that totally. we have some patients who are, I wouldn't say professional patients, but they take a big interest in their own results and they plot them. And they will say to me, I know that within another 4 weeks or 6 weeks, my ferritin will be very low. And we say, well, that's fantastic. Well, we'll intervene now. And then there's for the IV irons within the NHS, and we step in before we hit the floor with the ferritin, if you know what I mean. So prevent that massive drop and prevent the terrible brain fog. So anticipating what's coming in somebody whose history who has ongoing problems.
Absolutely. But there's still, education is always a way to go, isn't it?
Yeah.
There's still a lot of educating to be done.
And in terms of people who come in with a normal haemoglobin and iron deficiency, do they also feel the same benefit, even though their haemoglobin is normal to begin with and they have their IV iron? Do they still feel?
Absolutely. I've never had anybody come back and say it didn't work, which to me is a big thing, because people would always come back and say, look, I don't feel any better if they didn't, but nobody's ever come back.
So if someone watching the podcast feels this might be the treatment for them, what should they do next?
They should. So knowing their blood results is the first step.
They suspect they feel iron deficient, and so what should they do next? What's the steps?
I think people often start off feeling fatigued, don't they? So feeling tired all the time is probably one of those major complaints. Yeah. And so how does one diagnose feeling tired all the time? Well, you've got to go to your GP and run some routine blood tests, the commonest blood tests, to look for reasons as to why you might be feeling tired all the time. After, of course, a full consultation into whether or not, it's something, organic, or whether it's a mental health issue, but there's lots of reasons for feeling tired all the time. And then whittle it down to see if it is indeed iron deficiency, put together with the risk factors for being iron deficient, as we've talked about, so blood losses and diet and other malabsorptive syndromes, for example.
Yeah. No, I think it's important. I think the assessment is important, simply because somebody may have a problem which you think is obvious, like menstrual blood loss, but they may have additional problems, and so that's why I don't like patients just going in and buying iron over the counter, because they haven't assessed themselves.
Yes.
What happens if they've got malabsorption and menstrual blood loss, or say colonic polyps bleeding from the large intestine and menstrual blood that they haven't noticed? So I think we should dissuade people from self-prescribing and self-treating without an assessment either by the GP or specialist somewhere.
No, a full history and consultation is invaluable. Yes, it would tell us a lot. And you're right. Similarly, I've had a lot of patients who end up with one or two, 3 reasons as to why they are iron deficient.
Yeah. Yeah, because often you're blinded by the very obvious thing, and you ignore other things. Yeah. It's all menstrual, where you've forgotten that they've lost a few kilograms in weight, and there's other telltale signs that maybe isn't really obvious. And I agree with that.
And of course, anything like weight loss. If we see men who come to us with iron deficiency, that's a different kettle of fish, actually. They do need to be investigated, most likely with a bidirectional scope by a gastroenterologist if there is any iron deficiency in males.
No, I agree with you. I think if a male is iron deficient, which is very unusual, you have to presume there's some gastrointestinal blood loss somewhere until proved otherwise.
Exactly.
And hopefully the endoscopes, colonoscopy and endoscopy will be negative, but you can't assume that just from the history. You can't tell.
Yeah.
And what proportion of your population that you've done, of your 2,000, how many of those are men?
Percentage-wise, it's probably about 5% of those have been men.
And what's the underlying disease in the men?
There has been some inflammatory bowel disease. There have been some endurance athletes.
Oh, right.
In fact, and there've also been some with suspected malignancies, and those with post-bariatric surgery again, vegetarian diets. Yeah, so a bit of a mix.
Okay.
But they're always a little bit more complex, and we have to ensure that, and I would always ensure that they're investigated through the other proper channels. Yeah. No assumptions ever made.
Okay. And the endurance athletes, why are they anemic? Or why are they iron deficient?
Yes, so they're losing iron and sweat. They're also in a chronic state of inflammation whereby hepcidin is circulating around the body, and hepcidin, as you know, stops us absorbing oral iron or
and what kind
iron in the diet.
Sorry, I was going to say, and what kind of endurance athletes we talk? Is this marathon runners? What is this? Or
yes, people who are cyclists, runners, triathletes, that kind of thing.
Okay, that's interesting. I don't think
hard
that's well
training.
recognised medically. I don't think we're terribly aware of this group.
I don't think it is.
That's interesting.
Yeah.
That's interesting. So, my impression of iron intravenously is that there's still reticence within the National Health Service to use this as a mode of treatment, which is unfortunate, really. There's definite pushback from clinicians and from general practitioners. I don't know quite why there is this barrier. Do you have any idea why people are kind of frown upon IV iron?
So I think a lot of it stems from lack of awareness as to how important it can be to somebody to be iron deficient and what the clinical symptoms really feel like. Drew, thank you so much for joining me today. I think it's been very interesting. I hope you've enjoyed being here, and we're glad to have you as part of the team at Revive and Reset. And where can we find you on the socials if we wanted to hear a bit more about what you have to say?
Well, I'm very active on TikTok.
Okay.
I do lives most evenings for 90 minutes at 8 p.m. And iron deficiency is the number one topic which comes up on my lives. It's a recurring theme, so much so that I'm writing a book on iron deficiency based on my discussions on my TikTok live. So it's a hot topic because there are many people, this massive group of people who are suboptimally treated are looking for answers and they're not getting them. So they're on my TikTok lives. Great.
So you can find Drew on TikTok and follow us on Instagram.
My handle is Dr. Drew Provan, all one word, DREWPROVAN.
Okay.
If you want to find me.
Great. We've got that. We'll do that.
And you're on TikTok as well.
We are indeed.
And I follow you. Absolutely. Thank you for having me. It's been a real pleasure. It's great to hear about the service, how it's done. Hopefully, it will motivate people to come forward who are iron deficient, and they can explore the service. And it's great to be part of the team as well. So thank you so much for having me. Thanks.